and we'll talk about obviously vaccination in the state, as well as here in Craighead County, and try to get some of your questions answered that you may have on when can we actually get back to doing this in person. I know that's what everybody's asking. So.
Welcome to the weekly Rotary Club of Jonesboro. And ring our bell, call it to order. And inspirational moment. The only limit to our realization of tomorrow will be our doubts of today. Franklin D. Roosevelt. I'll turn it over to Neelam Yoshi to introduce our speaker.
Thank you so much, Gary. It is my honor to introduce to you all someone that by now probably needs little to no introduction. That is Dr. Shane Speights. The Rotary Club of Jonesboro has been fortunate to hear from Dr. Speights about twice last year as COVID-19 progressed throughout our state and our country. So today, Dr. Speights will provide you with the latest update on the virus, but more importantly, the vaccinations, as that's been the most recent happening. In addition to his role as the Dean of NYIT-COM at A-State and also being my boss, Dr. Speights is the Medical Director for the City of Jonesboro, and he serves as the Craighead County Health Officer. So please join me in welcoming Dr. Speights.
Thank you, Neelam. I appreciate that. And we'll talk about obviously vaccination in the state, as well as here in Craighead County, and try to get some of your questions answered that you may have on when can we actually get back to doing this in person. I know that's what everybody's asking. So hopefully we'll get some of these questions answered. Just real briefly, I'm going to run through. This is an overview globally, just as a reminder, though, as we'll talk about in a second, cases are going down. COVID cases are going down across the globe, and as well as here in the U.S. and Arkansas. We still are at about 27 million cases, though. We were still averaging about 1 million cases a week. It's interesting how things are relative. You know, if we talked about how high these cases are right now, just 3 months ago or 4 months ago, it would have been surprising. But we are significantly down compared to where we were right before the holidays. Still, unfortunately, 465,000 deaths here in the United States. Again, looking across at other countries, this is just a quick overview. Really, every country that we pick is seeing a decline in number of cases. So really over in Europe, over in South Korea, in Australia, any of those areas over there are all seeing a decline. There on the right-hand side where it says daily new cases, that's actually the global number. So you see there's been a global decline in cases, really, like I said, just across the board. We'll talk about Ireland in just a second. Actually, I'm going to show you a map of that. When you look at it across a logarithmic graph, basically cases per 100,000, you see that, again, all these cases are trending down. This is the U.S., France. Look at Ireland right there. I think this is an interesting, and it's worth talking about. So Ireland is this crimson, this dark red spike here. And we'll talk about this, but they had a spike there between April and May or so, and then they kind of held their own, saw another one there in the middle of October. And then this is what we would define, and you guys may remember this a long time ago. I talked about something called exponential spread. This is the time frame, really, there's kind of a perfect storm for them. The holidays hit, but there's also a variant over in the UK, and that variant also hit them. And they literally went from, well, you see, this is again 10 cases per 100,000 or 5 cases per 100,000. In a matter of 2 weeks, they spiked up to 130 cases per 100,000. So this is called exponential spread, and that it can happen that quickly. We talk about it, it's in the literature, we talk about it from an epidemiologic standpoint. It's rare to see it like this, but this is a perfect case of that. The cases, of course, then came down. Unfortunately, what happens after cases is the hospitalizations and deaths, and they're dealing with a higher number of deaths right now than most countries are. Here, turning to the U.S., when we look at the numbers here, we're on a downward decline. Our numbers are really about where they were right early November. Again, right before the Thanksgiving, Christmas holidays is where we are. So just right above 100,000 cases per day, which is significantly down, like I said, almost 3 times that is where we were there the very first week of January or so. We were kind of in the throes of it. You see our cases over the last 14 days are down 36%. Deaths are down over 10%. And the big thing too, which is great to see, is hospitalizations over a quarter are down across the country. We're seeing that again. This map actually looks. This is the map of the U.S. in terms of the number of cases. Looks very similar. If you'll remember it, it will look very similar to what we see in Arkansas in just a second. Speaking of Arkansas, unfortunately, on the right-hand side, we're at the number 2 spot in terms of cases per 100,000, behind only South Carolina. What else is going on in the U.S.? Well, again, we're seeing a downward decline in hospitalized patients. That's the graph in the top right-hand corner. Reported deaths per day, thankfully, is going down as well. That's a trailing number. You see that number go down after everything else does. And so it's good that those numbers are going down as well. This is just a brief look at where we in the state of Arkansas compare to our border states, Oklahoma, Missouri, Mississippi, Texas, Louisiana, those states there. Again, you can see they're all in a downward trend. Tennessee, I don't have that on here because the program doesn't allow more than so many, but Tennessee had seen a spike several weeks ago, a significant spike. And we were seeing that even in Shelby County over the Memphis area, but they too are on a downward trend. So all of these states are on a downward trend. So why is that? Everybody wants to know, and I've gotten asked that several times by the media, why are cases all of a sudden going down? Well, maybe the virus is just, quote, burning itself out. And that's kind of we throw that term around loosely. It doesn't necessarily happen like that. It can make genetic changes to where it's less transmissible and it just kind of basically, stops infecting people. Typically, the infection control measures, which is what we'd seen back in the SARS infection in 2002, 2004, that's kind of what happened. And this is SARS-CoV-2. The first one was SARS-CoV-1, again, back in the early 2000s, spread to 29 different countries. It didn't really hit the U.S. It kind of stopped at Canada and didn't really come into our country. That's why you didn't hear much about it. But basically, the infection control measures, being able to quickly identify cases and quarantine people, all the things that we're doing right now, those paid off, and we were able to kind of stop the movement as well. What about the vaccination efforts? Everybody's getting vaccinated now. Maybe that's why cases are going down. Well, really, we're only at about 2.8% of the U.S. population that's been fully vaccinated, meaning they've had both the first and second dose of the vaccine. So that in and of itself probably is not the reason. One of the things that probably is helping us, and this is just kind of the way it works, because we had so many cases in the past 4 to 6 weeks. I mean, here in the U.S., if you remember those numbers, and you'll see it here again for the state of Arkansas, we hit a big spike, right there in that January timeframe where a lot of people got infected. Well, once you get infected, you have antibodies. And so you have natural immunity, at least for a while. Right now, it's between 8 to 10 months is what the studies show. So between that and the people that are getting vaccinated, that's a fair number of people that have gotten the infection and have antibodies. Right now, what we think is, and let's just say, we know in the United States, we have 27 documented cases, 27 million documented cases of COVID in the U.S. Well, we know there are more people that have COVID than we have documented. So there's a lot of people walking around out there that either, it was just a runny nose or a headache. I didn't go get tested. I didn't want to get tested because I didn't want to miss work. I didn't want my kid to be out of school. There's a lot of that goes on. How much? Well, it's about 8-fold is the most recent number that was published in November. We thought it was between 5 and 10, but right now they've kind of settled on the number of 8. So if you multiply that 27 million by 8, that puts you at 216 million people in the U.S. that have probably gotten this virus or been exposed to it at some level where they might have some sort of immunity. That's almost 65% of our country. When you talk about herd immunity, and there's a big debate on this, what's the number for herd immunity for COVID? Dr. Fauci has put the number up to maybe 80, 85%. Some numbers say 70%. Some numbers say 70, 75%. It's kind of a moving target, and it is. The herd immunity number is still a moving target for us. But we can say with some certainty that a lot more people have had it, certainly in the last 4 to 6 weeks, than had it previously. And that does help with immunity. So if we can just continue to get a better push on vaccination, we will be in probably a better place as long as the variants don't throw us off track. And we'll talk about that in a second. Moving to the state of Arkansas, again, you can see that's where our spike was there in terms of our peak number of cases was there in the first really first 2 weeks of January is when we were kind of in the throes of it in terms of our highest number of cases. Very much mimics what we saw on the US side. We are down significantly. Just our 14-day change, we're down 13%. Deaths are down almost a third. And the big thing too, hospitalizations down 29%. I stay regularly in contact with the hospital CEOs in this region. They're all reporting numbers that are significantly lower and saying, look, we haven't had this few COVID patients in our hospitals since back in the early fall. That's all great news. Great news for our frontline workers, great news for our physicians and our nursing staff, respiratory therapists, really everybody in the healthcare system to be able to have a little bit of a breather right now from that volume they were experiencing back in January. You can see the reports there on the left-hand side, again, just shows hospitalizations are down, deaths are down. And the good thing too, because you think, well, maybe we're just not testing enough, the testing is actually pretty good. I mean, I say pretty good comparatively. So compared to the way it's been, testing is about the way that it was before. So it's not that we're really testing any less, and we're still seeing fewer cases. So that's positive. Here in Craighead County, numbers are down here as well. Just about 3 weeks ago, we were averaging about 87 cases a day in Craighead County. Now we're pretty much half that. So that's a good move. So even in our own backyard here, we're seeing fewer cases of COVID that are being circulated. And you can see again, our peak pretty much follows what the state did. Arkansas itself was averaging, right now is averaging about 7,400 cases per week, or about 1,000 cases a day. That's down significantly from the previous weeks. Our percent positivity, which is a number that we look at to make sure that we are testing enough people, it's coming down. I know these numbers are actually higher than we'd like. We really don't want it above 10%, but they were higher than this a few weeks ago. We were hitting 13%. I know hospitals were reporting 15 and 18%. So this is actually good news all the way around. So in terms of your good news section, that would have been the good news in terms of where we are for COVID cases here in Arkansas and in our own community. But let's talk about the variants, and not to rain on anybody's parade, but this is certainly something we have to talk about. First of all, these are some of the main variants that we're seeing and we're following. That's what I'm going to cover. One of them is the South African variant. Another one on this page is the UK variant. But I want to stop for a second. Where do these variants come from? The variants, or a variation or mutation in the virus, comes when it jumps from one person to the next. So as it reproduces and goes from one person to the next, there's a chance of a genetic change occurring. The more often that happens, the more likely there's a variation or mutation. So when you have lots of cases and when you have lots of virus spreading around, there's a lot higher chance that you will see mutations. Well, we just came away from big spikes across the US, even globally, and here in Arkansas. Remember, back in January, early January is when we were seeing our big spike in cases. That represents a lot of viral spread and the opportunity for mutations or variants to occur, and that's what we're seeing. South African variant, this is important because right now it's been found in a few states. It's important because what we feel, we're still learning more about these variants. We're not quite sure in terms of immunity. If you've had COVID before, are you covered from this variant? There's an article that came out today that I was reading about the South African variant, and there's question on whether you're fully protected. You probably have some protection, but it's possible that you might get infected again with COVID from this South African variant if you were to come in contact with it and you'd already had it. What about the vaccine? Does the vaccine cover it? We'll talk about that in a second, but right now we know Moderna, there's a 6-fold reduction in terms of its ability to produce antibodies to protect you from it. However, because Moderna is such a great vaccine, and really Moderna and Pfizer both, because they're so highly effective, even a 6-fold reduction still offers you good protection. So it would still work to protect you. The Pfizer vaccine actually shows only slightly less effective. So it's got good coverage against this South African variant. So that's good information on the vaccine front. What about the UK variant? What you need to know about it is it will likely be the predominant strain of COVID that is circulated in the United States and Arkansas by March. We have had a case already in Arkansas that's been publicized recently. There was a case last week in Memphis. This is in our area. We just haven't really been picking up on it because it's hard. We don't actually test for it. We don't test specifically for this variant. So the testing companies are having to recalibrate and rethink the testing approach to be able to pick up on this. We do send samples. The Department of Health sends samples to the CDC to try to pick up on it and see where it is. But I think Dr. Romero said this. He's absolutely right. This has been in Arkansas for a little bit now. So we're going to have to just kind of watch it and see from a hospitalization rate if we see more of an uptick from that. What about the UK variant? It does seem to be more transmissible, which means it's more likely that you'll get infected as opposed to the old variant. And the risk of death seems to be a little higher. Now, there's only been one report of this that's come out about the increased death rate, so I'm still waiting to hear more information about this, and I've kind of put the link there. They're quoting 30 to 40% increase, but I would put an asterisk by that because I'm not, that's retrospective or that's observational data, and so I'd like to see more information before really we come out and say absolutely this has a higher mortality rate. The Moderna and Pfizer vaccines both work against this variant. So you're covered if you've got either vaccine, you're covered against this variant. The variant that really is catching most people's attention is the one from Brazil. The reason why is because the variant from Brazil, right now, our current treatments and our current vaccines do not cover this variant. So the Brazilian variant is probably the biggest concern. And just so you know, it has shown up, I'll show you in a second, it's shown up in 2 states. Unfortunately, one of those states is Oklahoma, a border state of ours. It was found originally in Minnesota by a businessman who had recently traveled to Brazil. Why are you traveling to Brazil in the middle of a pandemic? I don't know. But he traveled there, picked up the variant, came back to Minnesota, and tested positive. It seems to spread a little more rapidly than the UK variant. And again, right now, it doesn't seem like even if you've had COVID or the vaccine that you're protected from this variant. And where they got that from is because the area there in the Manaus area, there in the Amazon region, they had COVID. They had COVID in that area back in April of 2020. They got hit pretty hard with COVID. And like 75% of their population, from what they think, and they did this, I think, through blood donations, got infected with it. Well, then all of a sudden they had this big spike of cases and like, where's this coming from? We felt like that we had most of our community was covered. And then it was individuals that had previously had COVID turned positive for this. So they're still investigating that data, still trying to figure out exactly what happened, but it is concerning. Right now, both vaccine manufacturers are working on a booster vaccine to be able to cover this variant. And this is actually what happened in Brazil. This is actually what it looked like whenever you had this downward trend in November. And this is what caught them off guard was this spike. So they felt like they had that they were pretty well covered from a lot of people getting COVID. And then they saw this spike and they've seen it again, even in January. So that's what kind of caused alarm. And that's really when they started to identify this variant. You can go to the CDC website and actually follow the variants and how many are in the US and how many states they're in. You see there the P1 variant, that's the Brazilian variant we were just talking about. It's in 2 states, Minnesota and Oklahoma. The B117 variant, that is the UK variant. That's the one that's going to be predominant. That's the variant that you're going to see that we have here in Arkansas that we're going to see predominantly in the US by March. It has the ability to pretty much, from what we're hearing now, double about every 10 days. So the number of cases will double about every 10 days. It's pretty rapidly spreading. Again, both vaccines cover this variant. So we feel somewhat better about that. And just this is the P1 variant that we're worried about. These are the cases that you see. And again, that was also from a traveler. The Oklahoma case was also from an individual who had traveled. So there are a couple of domestic variants. Again, when you see the virus reproduce, it's going to have a chance to mutate. And so there's one in California and there's one in Ohio. Haven't heard too much recently about the one in Ohio. The one in California has spread to several other states. It seems very similar in terms of how it looks. It seems very similar to the UK variant. It seems like it's probably 50% or more of the cases now in California. So following that. All right, vaccine update. We'll get into this. This is I'm sure what you want to hear more about. There's 3 other vaccines. You know, right now we've got Pfizer and Moderna. There's 3 other vaccines that you're going to hear about in the next few weeks. I know that Johnson & Johnson, I think, is set to go before the FDA on February the 26th to get their emergency stamp of approval, basically. It's a single dose vaccine. That's great. You don't have to come back and get a second dose. You don't have to wait for a booster dose 3 weeks later. You just get a one-time shot. 72% effective. I know that doesn't sound great. You're thinking, wait a minute, these others are 95% effective. What you need to know is most vaccines aren't that highly effective. What I mean is it was phenomenal to hear about a vaccine that had 95% efficacy. That was a big deal. And so 72% is good. I would not shy away from 72% effective at all. They say 66% overall because they tested in some other countries, which include South Africa, where the variant is. And that's what brought the number down. And we'll talk about that in a second. But they're hoping to have 100 million doses here in the US by June. Really, this summer, we're expecting a big rollout of a lot more vaccine. We're not getting near as much as we want right now. AstraZeneca, that's a 2-dose vaccine, 70% effective. And Novavax is also a 2-dose vaccine, 89% effective. And the AstraZeneca group, there was questions that came out, is it really effective for people age 65 and older? Really, they just didn't have a lot of people in that age group that took the vaccine. They have since enrolled a lot. And so I think the data will come out and prove that it is effective. But because you don't have the data, you can't really say that it is or it isn't. So that's kind of what they're waiting on. But again, that's one of the, these are the 3 big vaccines that you're going to be hearing about in the coming weeks in terms of coming out, and I think will be more broadly available. The Johnson & Johnson vaccine would be a big one just because, again, one shot, be great to be used for mass vaccination. You don't have to worry about scheduling another one, so you could bring in 3,000 people at the ASU arena there, line them up, give them a shot, and then they're good to go. So if we can get as much of that Johnson & Johnson vaccine, it shows to be effective, I think that would be really something important. What about the vaccines and their effectiveness against the variants? Because, you don't want to get a vaccine, all of a sudden you find out that it doesn't cover you from one of the variants that's circulating. Well, Moderna, right now we know it works against the UK variant and it offers some coverage against the one in South Africa. Doesn't work against the one in Brazil. Pfizer's the same way. Johnson & Johnson's only about 57% effective against the South African variant. I don't have any information about the Brazilian one. Novavax looks pretty good against the UK variant. Not great against the one in South Africa, and there's no data at all on the one from AstraZeneca. So this is kind of a wait and see. And so for those of you that have not gotten the vaccine yet and will be getting the vaccine, this information will likely change. So you'll have to look and see, what the vaccine covers as more data comes out. And really, that's the way this changes. I know certainly for me, and I'm sure for all of you, this gets confusing. It seems like every other day something new comes out or some new study comes out. And that's just, unfortunately, the world we're living in right now. They joke and call it an infodemic that goes along with a pandemic. And that there's a lot of truth to that. This came out from the Biden administration, so we'll see how that goes. They're purchasing an additional 200 million doses with 100 million from Moderna and Pfizer. And they're hopeful to fully vaccinate 300 million people by this summer. Well, the population for the U.S. is 330 million, so that's a big shot. That would be great. That'd be phenomenal if we could get that. So we're looking forward to seeing more vaccine come out. There are just actual restraints against getting that, so it's kind of a wait and see. In terms of vaccine rollout itself across the country, this again comes from the CDC, and you can actually pull this up yourself. What you want to look at is that number in the bottom right-hand corner. Number of people receiving 2 doses, because those are the people that are fully vaccinated. When you get your first dose, it's kind of a little primer. It kind of gets your body kind of set up for it. And the second dose really gets your immune system ready, to protect yourself. And so that second dose is important. So we're sitting at about 9.5 million people that have had that second dose. And the majority of people in the U.S. are getting the Pfizer vaccine. But Moderna has just increased their production as well. Here in the state of Arkansas, right now we're averaging about 36,000 doses a week. That's how much we get. And the vaccination rollout 2 weeks ago was 75% were going to community pharmacies, 25% were going to hospitals. And it was pretty variable, I'll be honest with you. There's a lot of frustration amongst pharmacies and frustration amongst hospitals. They would get, several trays of vaccine one week, they'd get nothing the next week. Same thing would happen to pharmacies. They get notified that we're getting no vaccine this week. I mean, so I think the state is working to commit to a constant supply of vaccine, even though the vaccine is limited in terms of what we're getting for the state. And it is 36,000 doses a week is not much at all. As a matter of fact, you can see the numbers there. Just in phase, if you look at the phase B, 1B, let's just take phase 1A out. Phase 1B, which is your K-12, daycare workers, college professors, and then anyone over the age of 70, that's a 450,000 people right there. Well, you can do the math pretty quickly. If you're only getting 36,000 doses a week and you need to vaccinate 450,000 people, it's going to take you about 2 to 3 months to do that. And that doesn't include the individuals that really from the national level, they say we should be vaccinating, which is 65 and older. If we just look in the state of Arkansas and say, well, who's age 65 to 69, that's another 460,000 people. So another 2 or 3 months. So we've got to get vaccine distribution higher in the state of Arkansas. I know the governor's working hard to do that. I know the Department of Health's working to do that. There are plenty of resources to actually administer the vaccine. We got ASU School of Nursing and Health Professions. I know NYIT, we've trained all of our first and second year medical students to give vaccines. So we've got well over a couple of hundred individuals who can give the vaccine. We just don't have the vaccine. And that's the same. I just actually, before I got on this call, I had a phone call with Dr. Jennifer Dillahay at the state. And, it's the same song, second verse. Right now, we just don't have the vaccine to be able to do it. We're expecting some increases in Moderna, and I think we're getting those. Right now, we have equal distribution. They're trying to get as much vaccine out into the rural areas as they can as well, so that kind of no stone left unturned, so to speak. At this point, they feel like that spread of the virus is really throughout the state, and that there's not specific areas of the state that are being significantly impacted more than others. I think there's debate back and forth on that, and there is, and I think that's collegial debate that should happen. They'd like to start talking about mass vaccination events, but there's just not enough vaccine to even pull that off. A mass vaccination event, you would want to be able to do at least 2,000, 3,000, 4,000 people. You can't do that right now and still commit to the same amount of vaccine for the pharmacies and hospitals that need it. You see on the right-hand side, really how we do as a state. We're about the middle of the pack. We're at the very bottom there on this one, but this is only about 22 states. And so we're, in terms of doses used, we're hitting about 74%. So we're about the middle of the pack. We bounce around. We sometimes will get in the top 10 or top 15, but right now about the middle of the pack as other states are picking up and working on their vaccine distribution. This is pulled straight from the Department of Health website in terms of total doses given. So I would encourage you, if you got any questions at all about this, you can see this. They've done a real good job in terms of transparency and being able to provide this information. You can also see what phase we're in as well as what phase we'll be moving to. Right now, we are in the first part of phase 1B. And that's what you kind of see there, first part of phase 1B. The second part of phase 1B is where you bring in food, agricultural workers, correctional staff, any individuals that weren't in 1A that are frontline, manufacturing workers, grocery store workers, public transit, postal service, essential government personnel, community workers. That's the second phase of 1B. I don't know when we'll go to that. They talked about going to that, hopefully in the March, April timeframe. Again, it all depends upon supply of vaccine, because you can open that up to people, but it doesn't change the amount of vaccine that you're getting from the federal government. I'll be surprised if we're able to go to 1C in April if we continue with the same amount of vaccine that we're getting now. So what about the vaccine? Who should not get the vaccine? This question comes up a lot. Well, if you're actively sick with COVID, you shouldn't get vaccine. And anyone, I always get this kind of blank stare, anyone with an allergic reaction to any of the vaccine components. And they say, well, Dr. Speights, what are the vaccine components? And that's a great question. Most of them you would know. If you, as an individual, had an allergy to a specific chemical compound, you would have known it. And so really that's what the warning is for that. And anyone that's if you've had the first dose and had a significant allergic reaction, you shouldn't get the second dose. But by and large, that's a pretty small list. So, I mean, even people that have had allergic reaction to the flu shot, or even they even go down and talk about people that have had Guillain-Barré syndrome, which is a neurological syndrome that can happen from vaccine. You know, they're not even saying those people shouldn't get it. So it's actually a pretty short list of people that should not get it. You've heard a lot about pregnancy, nursing mothers, women that want to become pregnant. A lot of the societies and organizations are saying those women should get it. Obviously, it's a conversation with your physician, but pregnancy in and of itself increases your risk of death by COVID by almost 13 times. So, and that does happen, and you can be hospitalized with it, and there's case after case about women because it's an immunocompromised state. Pregnancy itself is an immunocompromised or an immune modifying state. And so I don't think anybody wants anything like that to happen. What about side effects? Most side effects seem to occur with the second dose. The first dose, you're probably going to have some soreness from your arm, from the injection site. For me, it lasted about 24 hours. My wife was the same way. She had some soreness there at the injection site. Some people have a few symptoms of the first one, maybe a little bit of nausea or just not feeling well, but the vast majority are the second vaccine. Typically, they're going to make you wait at least 15 minutes. If you have some sort of allergic history, they'll make you wait 30 minutes. The vast majority of people that have had any reaction at all, it occurred within 15 to 30 minutes. There's a few outliers that we've picked up on, somebody like 120 hours out. That's extremely rare. What about that second dose? This is actually, I pulled this information from the vaccine manufacturers themselves. And so this is what they saw happen when they gave this vaccine to the 15,000 people in the second dose. And you saw, sore arm, 60, that's what I had. I had the sore arm, I had the fatigue and the muscle pains is what I had. My wife had the chills. She had some joint pain. She had a slight headache, no fever. So really between she and I kind of hit most of these symptoms here. They only lasted about 24 hours. I'll say this, they didn't start till about 18 or 20 hours after the second dose. So for me, my fatigue really kicked in about 24 hours after the second dose. She was the same way. But by the time I got up the next day after that and slept it off, I was fine. Again, she was the same way. We have to have that second dose because that's really where your effectiveness jumps up to the 94, 95%. And that's what you want. You want to make sure that it's fully effective. And like, again, right now, Pfizer and Moderna, those vaccines cover you from the UK variant. And that's what we expect to see widespread here in the US and Arkansas by March. So the vaccine does protect you from that. From both vaccines protect you from that variant as well. Other symptoms can be an upset stomach or some nausea. But again, pretty uncommon. What about anaphylaxis? Anaphylaxis is what we use for severe reaction. That's the term we use for that. The latest data says it's actually lower than we thought. For the Pfizer, it's only about 5 per million people. And Moderna, it's about 2.8 per million. These numbers that we're seeing on the safety of this vaccine, you got to know, these are better than what we see with flu shots. These are better than what we see with a lot of our vaccines. I'll say this, and there's already talk about it. Don't be surprised if our new vaccine platforms are the way this COVID vaccine was created. Would not surprise me at all. I don't think we really expected to see the effectiveness be so high. And to be honest with you, the side effects are so minimal compared to the millions of people that are getting vaccinated with this vaccine. This is probably going to be a new era in vaccines for us. And I think it's going to be if anything can be gleaned that's good out of this pandemic, this actually may be one of them. That they talked about the individuals that are at the highest risk of having an allergic reaction are females, median age of 39. Most of them had onset within 10 minutes, most about 30 minutes. And most of them had some sort of history of allergies or allergic reactions. So in terms of who the at-risk group is, it would be that group right there. They looked at nursing home residents in terms of those that were vaccinated. And when you do, this is going to sound morbid, but when you do calculations, there are things you expect anyway. So they expected out of 1.3 million people that just by chance, about 11,000 people were going to die just because of something else that was going on, unrelated to the vaccine. But instead, we've only seen 129 again. So that's, we don't feel like there's any relationship at all with the vaccine and nursing home deaths that occur there either. Median age for those individuals was 81. It was an even split, male and female, and over a third were in hospice. And I think that's it. I'll go ahead and stop and answer questions there. I know that was kind of fast and furious, so bear with me, but I'm happy to answer any questions you guys may have. I think I saw earlier, Dr. Raj. So anything I can't answer, I'm going to defer to Dr. Raj. You've got an expert here in your club that could give this presentation better than me.
Dr. Speights, there was a couple questions in the chat.
Okay. Oh, okay. Great question. I'm sorry. Great question on the vaccination of children. Yes. Let me give you that real quick. I'll do a quick run through on that because I've got that information. There are plans to vaccinate children. All four major vaccine manufacturers are currently doing studies on children down to age 5, as to what I'm familiar with right now. Several of them are looking down to age 12, but one of them is looking down to age 5. We really don't expect to have that information until late fall, though. But all of the current vaccine manufacturers that I just mentioned are in the process of doing that. And I was going to pull that. I have that data up. I posted something about that because somebody had that question about, what about kids? Because, there we go. Because those kids are going to, they're the ones in school. They're the ones that can spread it. They can bring it home. So right now, Pfizer has enrolled patients down to age 12. AstraZeneca is enrolling 5 to 12, but not here in the U.S. Moderna is doing 12 to 17. Johnson & Johnson is already testing 12 to 18. So we really hope to have an answer by fall of this year on kids vaccination. What happens if you can't get the second dose of the vaccine? So they've widened that a little bit. And what I mean by that is they used to say, it was like set in stone. Okay, if you get the vaccine, you got to get it exactly 21 days later or exactly 28 days later. Well, what happened then is, because you're not fully covered, people get the vaccine and like a week later they get sick with COVID. It's like, well, what do I do now? Well, then the recommendation was, well, you need to wait till you get over COVID, which is about 10 days, and then get the vaccine when you can, even if it's outside that window. The CDC has come out and said you can wait up to 42 days. So you can wait up to 42 days between that first dose. Now, it's kind of iffy in terms of the data, but the vaccine manufacturers, they're pulling it from the vaccine manufacturers package insert. But right now, that's the current guidance is you can wait up to 14 days to be able to get the second dose. So you should be able to get it somewhere in there. It's not going to be fully effective, though, if you don't get the second dose. And that's the concern, especially with the Pfizer vaccine. It's only 52% effective after the first dose. Moderna's a little better at 80%. But again, you really need both doses to be fully covered and to be fully effective. When will the variant boosters? So the variant boosters, when will they be available? Let me talk about that for a second. So companies are working on that again. Pfizer and Moderna are working on the variant boosters. It really would only take them about 6 weeks to get it done. They don't have to go through the whole process again. And what they're petitioning the FDA for is saying, look, our platform's already approved. You already looked at all of our data on that. All we're doing is changing, so that it covers these other variants as well. And so they feel like they shouldn't have to go through this whole process again. I think most people are like, yeah, you're right. You probably don't need to go through that whole thing again. They feel like they can have a variant booster up start producing it within 6 weeks. That'd be phenomenal. I mean, that'd be huge. And again, I'm going to go off on a brief tangent. Bear with me. If you know how we create our flu vaccine, that's a really big deal. The flu vaccine, we decide in January what we want the flu vaccine to look like for October of that year. And we have to figure out what strains are going to be in it. And then we grow it on eggs, and we got to grow it for 6 months on eggs. And then we pull it out, and then we create the vaccine, and then we stick it in arms. If we get it wrong, it's just wrong. We can't go back and do it. There's no do-over because we had to grow it for 6 months on eggs. This new technology, to be able to turn around in 6 weeks and fix it if all of a sudden we missed a variant, again, that's huge. That's a game changer for vaccines. Any correlation between someone who took the vaccine and was only, say, 30 days out from having had COVID, okay, and then getting the vaccine, okay, and then getting COVID-like symptoms after their vaccine versus someone who never had COVID, getting the vaccine and they didn't have any symptoms after their shot. Okay, so If you've had COVID and get the vaccine, they recommend right now, if you've had COVID, you should wait at least 90 days to get the vaccine. But it's not that there's anything that's interfering with it. It's just that once you've had COVID, you have antibodies. So you've got immunity, and you should let your vaccine go to somebody who doesn't have immunity or somebody who really needs the vaccine. That's why we say to delay that. It's not anything wrong with you getting it. It's just that we think that somebody else should probably get that vaccine and be covered by it. In terms of the symptoms, the symptoms are kind of similar, but it's because of the immune response. It's the immune response and that's really where the symptoms come from. So when you get the vaccine itself doesn't contain COVID. Let me be clear about that. There's no virus in the vaccine. It can't give you COVID. It's scientifically impossible for the vaccine to give you COVID. That just can't happen. It's just not the way it works. But your body's response could feel like it. And so because your body gets all mad and irritated, and what is this? And it creates all these helper cells and fighter cells, which cause inflammation and fever and upset stomach and headache and all of that. And that's really where your symptoms come from, is from your body's immune response. Now, further down the course, if you're infected with COVID, that's a different conversation if you end up in the ICU or that sort of thing. But in general, in terms of getting COVID and the vaccine, that's the deal there. What do you think is a change in the guidelines to safety with the state social distancing practice? I don't see, thinking about summer programs for children and youth guidance. It's going to depend upon the variants. If we continue to see cases decline and variants don't spread rapidly, I think that you may see something come out about that. It'll be interesting based on this administration. This administration will probably be more aggressive than what you were seeing in the previous administration. And you'll probably see different or I'm not saying restrictions, different guidance probably come out. I don't see the mask wearing going away anytime soon, even for people that are fully vaccinated. I had to explain this even to my own kids and my own family. It's like, here's the deal, guys. The vaccine's 95% effective. I'm fully vaccinated right now to 95%, which means that technically there's a 5% chance I could still get infected. If there's a chance I can get infected, that means I can pass it on to somebody who's not been vaccinated. So I need to wear a mask, not that I'm worried about getting infected with it, because the vaccines right now, 100% coverage in terms of me being hospitalized in the ICU or dying from it. So that's a huge deal when it comes to COVID. So I'm not worried about that, but I am worried about if I happen to get it and pass it to somebody else, I'd feel horrible. So that's why so the mask wearing, that's what you're going to hear about the mask wearing, and that's why. The social distancing, I don't see that changing anytime soon. Again, I may be wrong. I may be way off base. And it may be a different story. If the cases continue to go down and they keep dropping and dropping, I think we'll plateau, by the way. I think our cases will plateau, and I think we'll be holding at kind of a baseline infection rate for a while. But if they do keep going down, then yeah, you'll probably see certainly here in the state of Arkansas, you'll see some relaxing of that. The governor's already relaxed the restaurant order or the bar closing time. So that's already been relaxed. I would expect to see more of that as cases go down, but we have to really watch the variants and see what they do, because again, we don't have coverage on some of these variants. We don't have good coverage from the vaccine. So I think that's still kind of up in the air. It's probably too soon to tell. I'll say this. I have not canceled my summer vacation yet, and it's an out-of-state vacation. I've not canceled it yet, though I do expect to have a mask, and they may ask me for my vaccine card. If the UK variant is highly transmissible, but the current cases in the UK are falling fairly dramatically, is that a good sign? It means people got infected. That's exactly right. So they saw that increase in cases, and then it's going down. And so that's exactly right. Because whether you get infected with the current COVID strain or a COVID variant, well, once you're infected, you're infected. And if you make it through it and everything's fine, then you've got antibodies to it. And that's what happens to the population. So yes, that would be good. What we're worried about are these variants. Again, the Brazilian variant's very worrisome because it doesn't look like that whether you get infected by COVID previously or whether you have the vaccine that you're protected from that. There's some question about effectiveness from the South African variant. The UK variant, if you've got the vaccine, you're probably good to go. Dr. Raj could speak more to this. I believe if you're covered, if you get COVID, the current COVID strain now, I've not seen reinfection occur, or I've not read about reinfection occurring with the UK variant for individuals that have already had COVID. But again, that's the wild card in all of this is really the variants and the mutations, because if it mutates or changes enough, then your body may not recognize it and the antibodies may not be as effective. And so that's frustrating for sure. And that's why vaccination is a big deal. The way that you really stop variant spread is the vaccination. People get infected and a lot of people get vaccinated. So if you can get a lot of people covered either through natural immunity or through vaccination, that's what you want. I'm hopeful that we're going to really see a huge rollout of vaccine this summer, and a lot of people will get vaccinated in a short amount of time. We've not seen that yet. It's frustrating. We were hopeful we'd see more. That's the biggest thing that's slowing us down right now is vaccination.
All right, Dr. Speights, we appreciate you coming and sharing with us again. It's a great program as usual, great information. I said we are trying to figure out when it might be good to have an in-person and Zoom combination meeting. So it's always going to be a challenge. So hopefully these variants don't sidetrack us.
It is. I'll give you a kind of a sneak peek, because we're getting the same thing at NYIT, and they're like, what are you going to do? One of the things that we're kicking around is allowing people back into like right now we're remote, still remote like we were last spring, but allowing people slowly back into the building that have vaccination. So basically if you're vaccinated, you still got to wear a mask, but if you've got proven, vaccination status, letting them back into the building and start to kind of get some sort of normalcy back. We've been lucky to be able to get most of our staff and faculty vaccinated, even a good number of our students who are going to be frontline vaccinators, to be able to get them vaccinated. And so we are considering that and talking about that now. We're watching the variants, because the last thing you want to do is make a mistake on that. But it's just kind of a wait and see. But just so that you guys know, that's what we're talking about.
Dr. Speights, I had a quick question.
Absolutely.
Do you think that just because we're seeing these variants, it's highly likely that we're going to have at least an annual vaccine for this for foreseeable future?
Great question. And I think what you'll see, one of the questions that I'd seen come up was, well, how long, if I get the vaccine, how long does the vaccine last once I get it? And the Moderna CEO said right now in their studies and looking at vaccine degradation or breakdown, it seems to last for a couple of years. Now, that means that vaccine that you got lasts a couple of years, but in terms of what it covers, there may be a new variant, to your point. And that's where these booster vaccines come in. Remember, the variants and the mutations occur because there's a lot of spread. So when there's a lot of cases, that's when they have a chance to basically create new variants and new mutations. If you don't have a lot of spread, you don't have a lot of high cases, the risk of variations and mutations is lower. And so my hope would be that once cases are down lower, we won't see this many variants, and it won't be as big of an issue. Though I do believe that certainly for the foreseeable future, you'll get what's called a booster vaccine, like what we're seeing the companies work on now for the Brazilian variant. So I already know there'll be a booster vaccine for that. The question will be, 6 months from now, is there another variant they're worried about that they have to put another variant in? I do also believe that they are trying to manufacture a vaccine, a booster vaccine that tries to cover more variants. So tries to basically think about all the different variants it could be and try to cover that. So that's something they're considering now. My hope is, I would love for it not to be a seasonal vaccine, but it'd be hard to say that right now with what we're seeing.
Was it going to make a difference if we get the Moderna? Then are we going to have to get the Moderna booster, or will we be able to get the Pfizer booster or some other kind of booster?
That's a good question. I think you have right now. I think you'll have to stick with that manufacturer. That's not been clear, and there was information coming out about mixing of doses, and they've recommended against that. Like you got the first dose was Pfizer, can your second dose be Moderna? And there was a lot of conversation about that, but they're not recommending that. So it would not surprise me if they recommend that you stick with the same manufacturer. Now, what will happen is they'll do studies on it once it comes out, and they'll say, hey, oh, by the way, it looks like you're okay if you had Pfizer and you got the Moderna booster, that you'll be okay. Because, it's the same technology. It's the same technology platform. They're both mRNA vaccines. So in theory, you think that there would be some coverage there. But again, I think it's probably too soon to tell on that.
Sorry to throw those questions in last minute.
Oh, you're good.
Picking your brain is a rare opportunity.
I don't know about that, but
All right. Like I said, we appreciate, like Speights, appreciate the work that you do and your staff at NYIT and really all the medical workers in our community do a great job. And it's part of the reason Jonesboro is such a good community to be in. So
thank you. It
appreciate
certainly takes a team. So, and I appreciate my team. I know you got a lot of them here with you guys, and they just do outstanding work every day. I can't say enough good things about my guys and girls.
Thought for the day: the measure of who we are is what we do with what we have. Vince Lombardi. We'll adjourn and come back. See y'all all next week.
Everybody be safe.